Great. Well, welcome everyone. Hopefully everyone can hear me, and we're going to be doing a polling question here soon. Thank you for taking the lunch hour to hear our webinar today. Is this helping using assessment tools to monitor your client symptoms and your program outcomes? I realize probably most of you know who I am, but I think we have some new folks on here. So normally I'm the one who does the introductions of our speakers, but the tables are kind of turned today. So I'm going to just kind of introduce myself briefly to you all in case you don't know who I am. My name is Chad Severs, and I'm the project coordinator for Arkansas Building Effective Services for Trauma. So in the past, I would coordinate a lot of the TF-CBT trainings and consultation calls. Now I mostly do a lot of our contract development and statistical reporting. And of course, I do still organize our monthly webinars and things like that. But I wear a lot of different hats here. I did receive my graduate degree in social work from the University of Tennessee at Knoxville, and that's where I really learned to appreciate assessment and the data that comes with it, and whether people choose to use that information or not. That always interests me. And something that a lot of people don't know about me is that I also teach a class at Euler's social work program on statistics. So I really do like getting and understanding data and its uses and that sort of thing. So with that, we are going to go over a couple of housekeeping items. If you'd like to ask a question during the presentation, just use the little question feature that's on the right side of your screen somewhere. And if you want to earn a CU, just be sure to stick around to the very end. We'll have a code that's given, and you'll need to email that to me. And if you're watching this on our YouTube channel at a later date, we only give out CUs for attending live webinars. And also, if you're watching this as part of a group, just let me know, who is the person that's signed in, so I can just kind of verify that you're on the entire time. So we are recording this. We'll upload this presentation to our website, and it'll be available on our YouTube channel. Another housekeeping item bullet I didn't put on there is I also included some handouts for today's presentation, and they are instructions for our entire website and an interpretation guide for the UCLA and SDQ assessment measures that we'll be talking about. And I also just included this PowerPoint. It's kind of frequently that folks want to have that with them. So that's in a handouts little button. If you can't find that for whatever reason, just send me an email. I can get you those resources too. And also point those out where they are on our website. Okay, so what we're going to be covering today in this hour is just an overview of our database. We're going to share some statistics with you, and we're going to go over the basics on how to enter the UCLA PTSD Reaction Index and the Strengths and Difficulties Questionnaire. I'll show you how to print reports and how to look at those. And two other items that we'll talk a little more in detail is the TF-CBT checklist and our treatment plan. So that's sort of the agenda for this next hour. Okay, so before we get too much further, I've got a couple of questions I want to poll the group here. So I'm going to get those up, and if you would respond, I would appreciate that. So the first question is, I want to know, is technology a barrier? And so hopefully you can see that up, and just please respond. All right, I'll give it most of the folks have responded. Let's see, I'll close this. One last call to vote. Okay, I'm going to close this poll. And, oops, sorry, I hit the wrong button here. Oh, here we go. There's a share button. So for most of you, technology isn't not really an issue, but for some of you, it is. I totally get that, so don't feel bad. But that just kind of helps me just get a sense of where folks are at. Okay, I'm gonna go. Okay. All right. And the next question I want to know, make sure folks are kind of paying attention, is let me know. I'm curious to know like what you do for your agency. What's your primary role? Because I realize we might have a couple folks on here who aren't necessarily a clinician or a therapist, but are curious to know, are curious about this topic. Okay, it's just one last call to vote or put your answer in there, and we'll close that. Okay, so most of you are therapists or mental health professionals. Got a few administrators, a couple of advocates, no nurses, and other. Okay, so most of us are kind of from the therapy background world. Okay. All right, well that is helpful. Thank you for answering that. So our system requirements for the database, to enter this data on these assessment tools, is we run off, we developed it for Windows 7 or greater, and specifically be used with Internet Explorer 9 or greater. I think it's Internet Explorer 11 is the latest version. It does work on Firefox, Google Chrome, Safari, those other internet browsers. Fine, the interface might look a little bit different, but we test it with all those and it works. If you do use an older computer, Windows XP, you may be encountering problems. Microsoft no longer supports XP, and if you're having major issues with our database and this is you, it could be that operating system. So, but if you have any questions or concerns, just there's my contact information there. Email is the best way to get in touch with me. So, all right. So we might have a couple of folks on here who this might be their first time hearing about ARBEST, or and they want access to the assessment tool. So I'll kind of talk about that. So there's our homepage, and if you're a licensed mental health professional, you'll need to create an ARBEST account. And that little screen below there, text is a little small, but it says register for ARBEST. Go ahead and create an account. And if you haven't been to one of our TF-CBT trainings and completed that, but would like access to register kids and complete assessment results with them, email me after the presentation and let me know, and I'll grant you full access. Because right now, you don't have full access to the website if this is you. And if you forget your password, there's a link there. But we can always help reset that password if, for whatever reason, it doesn't get to your email account. So we're pretty much going to be staying in, this is just after you log in, this is the kind of the top pane of the website that you'll see. We're pretty much going to be in the patient care part of the database. But I did want to mention the downloads. The patient care is where we do our assessments, register kids, and that sort of thing. So I want to kind of focus on that. But this slide kind of gives you an overview of all those other things. So I'm just going to try to figure out this. Okay. Whoops. Oh. Thank you. You guys can't see my screen. All right. Sorry about that. Okay, so hopefully you can see my screen now. And all right. All right, great. Okay, now we're cooking with gas. Sorry about that, guys. Kind of learning this a little bit. Okay, so other couple screens before, not really important. You if you heard what I was saying, that's the important thing. So this is just a visual of our website once you log into the database. So when you click the downloads, this is where all our paper copies are, and there on the left are all our assessments and treatment plans. So you can click those, and a PDF will come up into a new window, and you can save that or print it whenever you want. And then on the right there, we have our instructions and how-tos. So like I mentioned in the very beginning of the presentation, I did include a couple of handouts for you, the interpretation guide for the UCLA and SDQ, and our website instructions. But you know, you can also access those through our website under the downloads. So the first thing you'll need to do before completing an assessment is you have to register a child into the system. And after you do that, you'll have full access to all the assessment tools. So to do that, again, it's under Patient Care, and then click Register Patient. And then you'll be asked to enter some basic demographic information about the child that you're seeing. And after you fill out that form, you'll be given this ID number, and it's important for you to kind of keep up with your own records because we don't know, you know, who Johnny is. We only see ID numbers and de-identified information. So we don't collect things like birth date. We ask, you know, birth month and birth year, but we don't ask for a day. We don't ask for things like Social Security or anything like that. So it's just important for you to keep up with that information on your own. I did want to mention kind of briefly, and you guys might have already seen this, but one of the first questions you're asked when you want to register a child is this child being referred from a child advocacy center? Chances are, if they are being referred from a child advocacy center, you probably have an idea that they already are. But what the intent and purpose of that question is we are one of the things we're charged with, ARBEST, is we're trying to figure out the kids that enter a child advocacy center, how are they accessing services if they need them? And so we're trying to kind of link the kid back to the CAC that they came from. So if they are, you'll probably get like a one-page piece of paperwork from the CAC. But if you click yes, it'll list all the child advocacy centers in our state, and then it'll ask for an ID number. The child advocates, the advocacy centers, they also have a database that's very similar to the mental health professionals, and where they enter demographic information and things like that. And so that's where we're trying to like link back these kids to those CACs. So this is just an overview of where the child advocacy centers are in our state. The red little pins represent kind of the home offices, and the green ones are kind of the satellite offices in our state. They cover all 75 counties, and each year they see about 4,500 kids. And so if you're not familiar with the CAC model and what they do, most of these kids are coming there because of an allegation of sexual abuse. And as most of you know, like sometimes kids where that's happened, they need, they could benefit from therapy. So stakeholders want to know, okay, if that's the case, then are they getting connected to those therapists? So for the fiscal year 15, this is just kind of a snapshot. Our CACs registered almost 4,700 kids into the system. So about 4,700 kids came to a child advocacy center from July 1st, 2014 to June 30th, 2015. And of those, about 3,000 of those were eligible for counseling. And what we mean by eligible are, these kids aren't already engaged in mental health services, or they're not already currently seeing somebody, and that, they're not from out of state or something like that. Occasionally a CAC might get a child from, a neighboring state or something. And we really want to focus on having them serve their own service area. So about 3,000 are eligible for counseling. And of those, about approximately 1,000 were seen by by a mental health professional that's affiliated with a child advocacy center. Obviously, that number could be greater, but it's kind of a capacity issue right now. So I really encourage you, if you are thinking about working with the CAC or would like to help, or just to start a conversation to to do that. They're always looking to refer to outside providers and stuff. So. Okay, I'm going to share a couple of these next several slides are just some stats of what kids look like, the kind of their characteristics who have been entered into our system. And so this is all data from fiscal year 15, and therapists entered a little over 2,000 kids into the ARBEST database. If you have any kind of questions or need me to pause to talk more about a chart or something that you see, just let me know. I realize that I've also got this PowerPoint available for you to kind of look at later too. So, but most of the kids entered into the ARBEST database were female. They were Caucasian, white. The average age for a child enter our system is about 10.5 years old. And the majority of them are between the ages of 3 and 17 years old. So those who have been to one of our TF-CBT trainings know that TF-CBT has an evidence base of, for kids 3 to 17, up to 18. And so we got a few, really young kids and some older ones, but majority of kids kind of fall within that category, that group. The trauma type, most kids are, the trauma that they've endorsed is sexual abuse, but that's followed up by physical and witness violence. The sexual abuse is probably higher than you might expect because, again, this is also includes data from Child Advocacy Center therapists, and they do enter quite a bit of data for us. So most of the cases that they see involve an allegation of sexual abuse. The good news is that most of these kids looks like they're getting seen with pretty close to when the actual trauma happened. So that's positive. You can kind of see the breakout with the others there. The number of traumas. So when you register a kid, you can say, yes, they're here for sexual abuse, but, we allow you to check as many as kind of all that apply. So about 8% of our kids in fiscal year 15 endorsed 3 or more traumas. So they were sexually abused, they were physically abused, and they witnessed violence. But the majority of them only endorsed 1 trauma, like they were only experienced physical abuse. That could have happened multiple times, but they only endorsed 1 type of trauma. So hopefully that makes sense. But so for a quarter of these kids, I mean, you're talking about some really complex trauma issues. All right, and here's some data on who the offender is. The one on the left there, just kind of the type of the offender, and that represents about 30% of the offenders, either a parent or a step parent. And we've got a quarter of our kids say that their offender was somebody who was under the age of 18. And so that's something of late that a lot of decision makers and folks want to try to figure out how do we, what's going on there, and how do we work with those kids who are not only the victims but also the offenders. Okay, we're going to get right into probably a lot of you want to know, how do you assess for trauma, and talking about the assessment tools on our website. So I'm going to ask another polling question here. Okay. see here. Okay, so how do you assess for trauma? Just take a minute to answer that question. And a few more moments to answer that. Okay. Last call to let me know how you assess for trauma. Okay. Okay. So looks like most of you use the your clinic's intake assessment, but a quarter of you use the UCLA. Okay. So all right. Okay. All right. So let's talk about our assessment tools that are available on the ARBEST website. But before we do that, I think a lot of times folks have this. They hear the word assessment, they maybe have this image in mind. Huge bunch of paperwork, maybe overwhelming. I really hope that, hopefully that kind of shifts or goes away, because it can be really, really valuable. And the overall purpose for assessment, as a lot of you know, is just to kind of capture a better picture of who this child is. And so we can do baseline and follow-up data. We can see progress or not, or where areas we need to work on. But sometimes that's hard when we're sort of kind of in the moment. But so I just kind of want to encourage you, if you're one of those that just are really, gosh, I don't like doing assessment, I don't see the benefit of it. I mean, I get that. Sometimes you're asked to do things, but there's no feedback on what you're doing, and that can be really frustrating. So hopefully our tools on our website aren't like that, and you do get feedback, and it helps you maybe guide what you're doing. I don't think it should take away from clinical judgment. It should probably use, in concert with it. So you're using your clinical judgment, and what is that assessment tool telling you? Okay, well, the first one, I'll just kind of explain which ones they are. On our website, we have the UCLA PTSD Reaction Index. And, I encourage you, to kind of Google these and do your own research. But the UCLA is the one we use for assessing trauma. And this is the version that's mapped for DSM-4. ARBEST has been grandfathered into using this instrument. Now, I think the DSM-5, you have to pay for. We're not able to use it just yet. So anyways, and I also want to mention too that we don't get any sort of monetary benefit for using these assessment tools. We just, as a team, decided these were kind of the two best tools to use. And the Strengths and Difficulties questionnaire looks at the kind of behavioral concerns. And so we'll first talk about the UCLA, how to enter that, a little bit of background information on it, and like how to print reports. And we'll look at some data too, some stats. All right, so for the UCLA, I mean, we really want you to assess your client symptoms at baseline or at intake. I mean, that's ideal. Sometimes the question that I'm frequently asked is, look, I've been working with this kid for a couple months. Maybe trauma is sort of something that we need to address. Can I do a UCLA now? Absolutely. Yeah, you can do UCLA kind of mid-treatment, and that would be your baseline. So, and then we really want you to do 3 follow-up points. 3, 6, 9 months would be ideal, because that really is going to show us, the progress, and we'll have some good outcome data for that. I'll show a slide or two that, kind of ask that question: Are kids getting better? So if you do register a kid and complete a baseline, we will send you a reminder email when those are due, just to kind of help, again, to just remind you on that. Okay. The UCLA is a brief screening tool, and again, it's looking at trauma exposure and PTSD symptoms. The items do match to the DSM-IV criteria, and it produces this overall traumatic stress symptom score. And so basically, if you're about to be on the consultation calls, or you're working with a kid that who's had a UCLA done, and you ask for the scoring, anything that's 38 or above, it's probably a good likelihood that that kid is going to have enough things to warrant a PTSD diagnosis. That's really simplifying it, but that's kind of the cut score, if you will, that folks kind of get stuck in. They kind of look at that. So 38 or above. Oftentimes, though, especially folks maybe you're new in trauma work, or this is, doing assessments for kids who have experienced trauma, or maybe hesitant to do that at first. But what we found is that, kids really do appreciate you asking, or just kind of clarifying, kind of getting out there on the table. Parents sometimes just don't realize that it really impacted their child that much. And at the same time, if something did happen, the results could show this kid's pretty resilient. They probably are managing just fine, and maybe don't need full-blown TF-CBT. And it's also just good for observation. So if you are working with a kiddo who's had some pretty horrendous abuse, and they're just reporting everything's fine, I mean, again, just kind of use your clinical judgment, and with that assessment tool, and make an informed decision or judgment about that. You can pick up a lot of nonverbals that the score is not going to tell you. So we always advise folks to kind of complete that assessment, the UCLA, with the child or with the parent, in case they have any questions, or if you have concerns about their reading level or anything like that. I'm going to check in, see if there's any questions. Okay, I do have a question here. I'm going to just try to answer this. Okay, so one of the questions was, do we need to inform you about when we give the baseline so that you know when to send us reminders? No. So when you enter a UCLA, and I'll show that here in a couple of slides, you'll actually enter in a date. So it's kind of based off that date. So if you did one today, the reminder would kick in like 3 months from now, and it'd be sent to you then. So hopefully that answers your question. All right. Oh, another question about the UCLA, and that's fine. So if you have questions, this is the time to ask. Okay, so we can read it to the kids if they aren't at the reading level they need to be. Yes, and I'll talk about if they're under the age of 7 years old, the parent or caregiver needs to be the one doing that report. They're going to be a better reporter probably, and we can write the answers for them if they can't for some reason. Absolutely. There is sort of on the first part of the UCLA ask, kind of like, what happened? What's the trauma? And there's that other box. So, if none of those items, they weren't in a car wreck or they weren't sexually abused, but something other bad happened, yeah, you can go ahead and type that in there or write that in for them. That's perfectly fine. Good questions. Whoops. Okay, so these next slides are going to show you kind of where on our website, the buttons to push, if you will, on how to enter that. So after you've registered a kiddo, you can go back to patient care and click add under instruments. And let's see here. That little checkbox there, some therapists, kind of their styles, they want the child or parent to sit at the computer and enter the assessment. They maybe feel that the child might be more open versus, somebody like looking over her shoulder or whatever. So if that's the case, just make sure to check that box so that after they complete the instrument, they will be logged out of the system. If you're the one entering the data, after the session or whatever, you don't have to check that box. You can just, because otherwise it would keep bringing you back to the login screen. Okay, so you really need to have the same person completing the baseline should complete the follow-up. I mean, hopefully that should make sense. We have parent instruments, and a common question is, in our paper copies, you might have noticed that, well, the UCLA says for children under the age of 12. We encourage you to, you can do a parent instrument on any age child. So as kind of a short answer to a longer explanation. And it's really ideal to kind of have both. If you can have your adolescent complete a UCLA and a parent, you can kind of compare those two, and you probably would get different scores. And again, that's going to help you just better see what's going on. And we do have under the optional modules is where we have the child UCLA, and that has been validated for kids ages 7 to 12 years old. We don't have an assessment for that young for the SDQ available on our website. So if you have younger kiddos, like under the age of 12 for the SDQ, the parent SDQ is going to be your best bet. Okay, so this is a screenshot of the UCLA. So let me back up the screen there. So after you click, whether you're doing the parent or adolescent, you click on that PTSD. You're going to see this screenshot, and the first section is just going to be asking about what happened. We give you a little text above there about maybe kind of how to coach or how to explain the assessment tool to a child or parent. So if they endorse no traumas, we're not going to be able to get any information from that. So a child has to have experienced some traumatic experience. It may be in their referral chart that they did, but if they endorse no to all that, we're not going to be able to give you an overall score. Because then all the information, say for instance that this kid, like being in an accident was this super scary thing that happened to them, all the following questions are going to be kind of related back to that. So when you were in that accident, So, okay, one of the common issues, this is just another screenshot of the UCLA, is that on the parent measurement, especially for, I would say, like foster parents or that are maybe just kind of, they don't have a lot of background information on the trauma, or they weren't there, so whatever, they might have a tendency to answer don't knows a lot of the time. The assessment will save, but it won't be valid. And how our system treats don't knows, it's like they skipped a question. So if there's too many skips, we're going to kind of throw that out. We're not going to be able to give you a reliable score. But that can also provide you with valuable information. Even though you don't have a valid UCLA, look, mom or whoever, grandma, they clearly just have no idea what has happened to this kid, and okay, that's maybe also something we need to work on, or you have to kind of figure out. So just to kind of keep that in mind, if mom or whoever the caregiver is answering too many don't knows, it's going to be saved as an invalid assessment. All right. So after you've entered in all your answers to the UCLA, how do you review those reports? And so under the reports column, if you completed a child UCLA, it would be there. If you completed a parent, the patient's actually an adolescent version, that field's going to be highlighted with a link where you can see the report. So this is just an example. This is just some data that I put into the system. And I'll explain the scores a little bit in more detail here. But, we have a baseline and then we have 2 follow-ups. So, we want the scores to go down. Lower scores means, lower trauma symptoms. So lower scores are good. That's kind of what we want to see. We have sort of a, the significant distress are those scores at 38 or above. So if kids up there, it probably would meet, according to DSM-4, diagnostic criteria for PTSD. And then you kind of have like the significant distress and moderate distress. So let me back up a little bit. So this is going to be your first report that you see, your first little graph. The second graph breaks down the 3 symptom clusters: arousal, avoidance, and intrusion. And it shows you how those are kind of mapped over time, which could be kind of a good, important tool to use, especially if you're doing, say, TF-CBT with a kiddo and you're about to do the trauma narrative. You may, after the trauma narrative, complete a UCLA or before, just to kind of check on how the kid's doing. Their avoidance might be going up, but everything else is going down. So again, it's meant to sort of help you with kind of working with that kid and kind of what, are the pressing concerns or symptoms that you need to be addressing. And the third little chart this is the individual symptoms. So this kind of really breaks it down. And this chart is unique each time that you complete a UCLA. So if you want to save this information, like if you really want to get down in the weeds and look at how they answer differently, my advice is just to save these as a screenshot or save these as PDFs each time. But you kind of see how they're organized. We have the intrusion symptoms, the avoidance, and the arousal. But each time you enter UCLA, this chart changes. We don't track this over time. Okay. So if you have any questions about administering the UCLA or that, please let me know. I'm going to share a little bit of data with you. So ARBEST has been collecting this information since really about April of 2010. So we have about 2,000, baseline UCLAs in the system. And this is the average parent UCLA. It's at about a 27. So remember the magic number is that 38. And just to kind of orient you a little bit on this graphic here, this frequency is just the number of kids or number of parents that responded that way on the y-axis, and the x is the severity score. So you can see my mouse here. The ones that answered 0 or nothing, everything's fine. So they had a UCLA score of 0, and kind of on down. Let me get here. All right, so those bars that are in red, those are the parents that said that reported a score of 38 or above. So kind of keep this image in mind, this graph. And this is the adolescent version. So I'll kind of go back and forth a little bit, but one of the things that, and you probably already know this if you've done assessment with kids and parents, is that, a lot of times, especially like self-reports, the parent really doesn't know like how the child is feeling or how the child is experiencing something. So they might have a tendency to maybe under-report a little bit. Whereas sometimes the kids might have a tendency to over-report a little bit, or kind of, so you just have to kind of weigh everything. but that's, I think, again, if you can get UCLA from a parent and a UCLA from a child, and then, kind of sort that all out, is going to be your best case scenario. That would be ideal. But generally, adolescents maybe are probably better reporters about their own symptoms. Younger kids, probably parents are maybe better reporters of those. Okay. Alrighty here. Okay. So are our kids getting better? And this, again, is just all data since 2010. And these are just our average UCLAs. And we have some pretty good data on some baseline and follow-up. So we have about 444 parents with, these are matched baseline and follow-up. So, in both cases, we want these scores to go down. So we want those red bars to be lower than the blue bars. And for the, let's see this here, my screen's getting covered. And for the adolescent, about the same number of respondents. So in both cases, when we've been using TF-CBT with our kids, it does appear that their symptoms are reducing, and that's what we want to happen. That's kind of the goal. Okay, so I'm going to stop talking about the UCLA for a bit, and we're going to shift on over to the SDQ. If you're about to be joining the consultation calls, one of the requirements for you is that to complete 2 UCLAs. So that's the requirement for our folks that are about to join the consultation calls. They need to complete 2 UCLAs on 2 different clients. And so if you have any questions about administering the UCLA after this, let your call leader know, and they can get back to me, and we can kind of help out with that. I mean, that's a big part of my job too, is providing technical assistance for folks on how to administer things, or website issues that come up. Okay, so the SDQ is going to look at behavioral concerns. It's a behavioral screening tool, and it again yields an overall distress score, and I'll show you some things here in a bit that talks more about that. And it breaks it down into the emotional symptoms, behavior problems, attentional difficulties, peer problems, pro-social behavior. And so if your SDQ score, that if you administer this on a child, if it's above this clinical cut score, there's going to be a higher likelihood of them, actually having a diagnosis that could be, DSM-4. So if they're above, there's oh yeah, if they really score high on the attentional difficulties, then, they might have a diagnosis that, falls in line with that. If they're below the cut score, there's not so much concern. But it's really meant to sort of, as a screening tool, as a guide, if there are any kind of behavioral issues. Oftentimes there are when you're working with kids who've experienced trauma. Sometimes that's the reason why they're referred to you, because they are really hypervigilant, and they might have thrown a chair across the room, or they're getting in fights or whatever, or the kids that are really quiet, depressed, things like that. So we know kids who have trauma histories sometimes also have behavioral issues that we need to address as well. Okay, and so just to kind of remind you that the SDQ is in the same spot as the UCLA. So again, it's under patient care, and then you would click add under instruments. And so, if you were to complete it, the parent was going to complete an SDQ, that's where they would click. This is just a screenshot of the SDQ. And this is a report example. And I'll show you here in some data and some other slides here. I'll talk about more about the clinical cut scores and stuff like that. But again, the same thing with SDQ. We want the scores to be, the overall score to be lower. That's kind of the goal. So these are the individual SDQ scores here. and we want them all to be lower with the exception of the pro-social behavior. So that's why that's kind of starred. That's that blue line there. We want the pro-social behavior to actually increase. So all the rest we want to decrease, but the pro-social behavior is opposite. All right, and here is just another kind of histogram of like baseline parent SDQ data. So on the parent version, the clinical cut score is 13. And so basically all those above that, the SDQ developers, they kind of put them into different groups, kind of the mild and, I'll put them up here. We've got the low group or not so much a concern, medium distress or some medium concern, and we got the high risk. So this is how the parents responded to the SDQ. And the adolescent, kind of like the SDQ we just saw. So again, these are the frequencies, the number of kids, and the x-axis is the SDQ score. The clinical cut score for the adolescent or self-report is 15. And so those below 15, not as much of a concern. Above 15, we probably want to pay attention to or kind of figure out what's going on. It's kind of a over simplistic takeaway message from that. Okay, I'm just kind of checking time here. Okay, so I don't have anything else on the SDQ. I do think that a lot of our folks who use it, they really like it. It kind of gets, it gets into those behavioral things or how you might want to plan around treatment. So if you do experience any kind of technical difficulties or anything, just please let me know, and we'll be happy to help. There are a couple other tools available on our website that can help with treatment planning and that sort of thing. The first really applies to folks who are doing TF-CBT. And so trauma-focused cognitive behavioral therapy is an evidence-based intervention for kids who have experienced trauma and have PTSD symptoms. And we've borrowed this with the permission of the developers of the model to put it on our website. But the checklist is really meant to kind of keep folks on track of where they are in the model. And so under patient care, you click there, and then you can add a checklist for one of your patients if you're doing TF-CBT with them. And this is a screenshot of what that looks like. And so, we asked for the date, time, and stuff like that. And one of the reasons why we asked for some of that information up top is we do some contract work with our child advocacy centers, and so we've got to report that, the hours that the direct hours that they're working with kiddos, that we can then report that back. But this also just is when we generate reports, and I'll show you a screenshot here in a second. That you kind of jogs your memory of like, okay, last Tuesday, this is when I worked with this child. And the TF-CBT checklist is organized by the practice acronym, so psychoeducation, relaxation, and so on. And so if you're working on psychoeducation, for instance, that day with the child, there's what did you do with psychoeducation? And so, here's the report of what it looks like. So the most recent session is on top. This is just some fake data here that I entered in. And so you can see you got a couple different start dates, what you addressed. And this can be helpful for, if you are, have done psychoeducation for the past, 8 weeks, you haven't really moved on, then, hopefully, by then you probably need to progress or ask yourself why you aren't moving on. If you're participating in the calls, it'd be a great topic to bring up on the consultation calls. We do have a section at the very bottom of that checklist if you kind of wanted to add like a little note to kind of explain maybe more in more detail or whatever, it's totally up to you. That's just a report example. Okay. And then the other thing that we have that we don't mention too much, but we also have developed a treatment plan, and we designed this around the Medicaid guidelines. So coming up with goals, measurable goals and objectives, things like that. We also, the treatment plan, kind of all of our goals and objectives and things like that, you can download and use and look at, get ideas from. But kind of the three problems that they look at addressing are, dealing with traumatic stress, depression, and disruptive behavior. And so that's where the treatment plan is. You can add that. And this is just a screenshot. So, in this example, you can, the traumatic stress, the problem one, there's several different problems you can choose from. And then what are your your objectives that you want to work on with that child? And you can, choose from the list that's available. And this is a report example. It actually prints out the entire treatment plan, and then the little green check marks are what you, the therapist, check for your client. So, that's kind of, you can adjust this if you want to change it. Some folks find this helpful sometimes it's difficult to come up with those measurable goals and objectives. And so, this is another tool that can be available for you to use. And I mentioned this at the top of the webinar, but downloads, make sure you check those out. That's where all our paper copies are. On the left there, we have all the assessment tools, and then on the right are like our website instructions, the SDQ and PTSD interpretation guide, which is also included in one of your handouts. But if you ever have kind of questions about that, wanted more information, please let me know and contact me. All right. So as we're kind of wrapping up the hour here, of course, why we want everyone to, not only do we want you to get benefit from it, but we're also able to take this data and information back to the state and argue for more funding or continued funding. If you're thinking about completing the TF-CBT training process, whether you're here in Arkansas or another state, they're going to want you to do a standardized assessment, a trauma assessment with a kiddo, and a UCLA fits that. So it kind of fits in with your TF-CBT training process. And of course, if you're with the CAC and you're affiliated, it's a requirement for funding. So it's going to help give us a better picture of what's going on in our state and how we can best help these kids. All right, so I'm going to just pause here and answer any questions that folks have, things like that. I'll kind of be quiet for a little bit and wait for some questions to come in, and then I will forward the CU code and that sort of thing. But that's our website database in a nutshell, and what we do. So feel free to type in any questions that you might have. Okay, we got a couple of questions. I'll try to take them. Alrighty here. Okay. One of you had a treatment plan. Some of you had a couple of questions about the treatment plan, and that the treatment planning is going to be under the patient care. I'm just going to kind of back up to that slide. Here it is. There's the treatment plan. If you want to add that, so hopefully that answers your question. And it's also available to download under the download section. Okay, one question, have parents ever expressed concerns regarding these assessments? For instance, about their accuracy of interpreting behaviors, etc. I'm sure they have, and I'm honestly probably not the best person to ask that, but I can put you in contact with someone who can answer that question more. I mean, I think one of the fears is, parents might be resistant to answer something. Maybe they're involved with DCFS or something. There's just a mistrust there. But yeah, there is kind of the art of engaging families, and really it's to help you kind of work with that child the best. Okay, and somebody asked, would it be helpful to go ahead and complete an assessment even if we might not be able to follow through with TF-CBT? Yeah, I think so. I mean, it probably won't hurt, and it could probably just and maybe kind of the context of that is the child's going to be leaving your care shortly, or for whatever reason they're just there for a short amount of time, but you might get a snapshot of are they symptomatic? Are they experiencing symptoms? And depending on your agencies and stuff, maybe pass that information along to others, or let the family know, or give that information to the family. So yeah, I don't think there's any harm of completing an assessment, even though you might not follow through the TF-CBT. The UCLA is not mutually exclusive to TF-CBT. It's a trauma assessment. And it was one of the first, I guess, to be developed for kiddos. But okay, great questions. Okay. All right. Well, if you do have questions, I may have answers, or I can find people that have answers, but there's my contact information. And so hopefully, this is kind of maybe a refresher for a lot of you. For a while there, the SDQ was off the website, but now we have it back on. So that might be some new information for folks who have been with us for a while. But yeah, I mean, this is part of my job. I want to help you work with the kids the best that you can. So email or give me a call. Be happy to talk to you more. And so I'm going to go ahead and give you guys the CU code. And so when you email me, make sure that you give me your first and last name. That's always helpful. Makes my job a lot easier. If you're watching in a group, let me know who was the person that signed in to the webinar. If you're someone that's brand new and does not have full access to our website, a couple of you have emailed me already, but just email me again and let me know that, hey, I just was on the webinar today and I need full access to the website, and we'll get you set up. So, and I'll kind of stick around here for another couple minutes and answer any other questions. But all right, last call for questions. And yeah, if something comes up, just send me an email and I'd be happy to answer it. So I'm going to sign off, and thanks for listening today.